Hey, good morning, Cassidy. How are you?
Good morning. It's good to see you. Thank you for allowing me to participate today.
Yeah, thank you for participating in all these. Just let me have member Lunge, Dr. Merman.
I'm here.
Sarah Lindberg. Okay.
Russ and I are in the conference room here.
Perfect, nice. Okay. And do we have everyone from the University of Vermont side? Good morning, Dr. Ethan. How are you? I think you might be muted.
If you were waiting for me, I am all set. I apologize.
No problem. Nice to see you. Dr. Ethan, do you have everyone that you need from UVM?
Take a look. I think so. Rick, will you verify?
Yeah, it looks like we're good.
Great. Okay, so I'll call to order the Green Mountain Care Board's hearing of August 23rd, 2023. I think there's one agenda item today, which is the UVM Health Network and its hospitals in Vermont's fiscal year 24 budgets. Before we get started, it's come to my attention that UVM's requested that Dr. Merman not participate in a review of its budgets. And I think given the concerns that have been raised, I should address that up front. UVM's filed a motion seeking Dr. Merman's recusal because it believes he's conflicted. Dr. Merman's received an opinion from the Ethics Commission and has a written statement on file with the GMCB as required by the Code of Ethics. UVM believes there's other information that it thinks could change that analysis. And UVM's motion that we received yesterday indicates that it does not object to Dr. Merman's participation today in the Medical Center, Health Network, or Porter hearings, and asks the board to take up the recusal motion at a later date prior to deliberations. I think somebody's unmuted. If you're not speaking, could you please mute? Might be somebody in a car. Thank you. So I think that is a reasonable way to approach the issue, to have Dr. Merman participate in the Medical Center Health Network in Porter and take up the recusal motion at a later date. So we're going to proceed in that fashion today. Dr. Merman is recusing himself from participation in the CVMC budget and will not participate in that part of the hearing. With that out of the way, Mr. McCracken, could you please swear? Oh, sorry, one other thing I should say is that there's a lot of material here. We may go quite a bit longer than scheduled. Those times are pretty approximate. So if you need to leave for any reason, just perhaps send Kristen Lajeunesse an email and let us know. But I think we're going to be here probably a little bit longer, or maybe even quite a bit longer, especially because we have a request for an executive session that we may take up. So with that, Mr. McCracken, if you could swear the witnesses, and then Dr. Epen, you and your team can proceed with any opening remarks you may have.
Good morning, everyone, and thank you, Chair Foster. I have the list of witnesses from the different UVM Health Network hospitals. It is a long list, so I'm not going to read through it, but for those identified on the list, if you could all raise your right hands, I will swear you all in at the same time. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
I do.
Great, thanks very much, and I will turn it over to the UVM team for opening remarks.
Great. Thank you. Sunny Epen, I'm going to just start with the opening remarks and then hand it over to Rick Vincent. First of all, thank you and good morning. Thank you in advance for what I trust will be a careful review of the proposed fiscal year 24 budgets for the UVM Health Network's Vermont Hospital partners. This includes the University of Vermont Medical Center, Central Vermont Medical Center, and Porter Hospital. We strongly believe these are responsible and reasonable budgets that will allow us to meet the needs of our patients and communities and continue to move us towards financial stability, while limiting to the greatest extent possible the financial impact on Vermonters. These budgets have been carefully reviewed and approved by our network board of trustees, which is made up of community volunteers. Our trustees take their oversight duties seriously and embody exactly what we would all hope for in our governance: compassion, awareness, and a deep sense of responsibility. I'd like to thank our network trustees who are joining us today, including Allie Stickney, John Dwyer, and Tom Galanka. I also want to start by acknowledging the very difficult task before all of us. Every person participating in this meeting shares the same goal: to contain healthcare cost growth and improve healthcare system performance in Vermont, where in a national context, there has been no one else able to fully achieve these goals. Our entire health system is committed to working with you to address both cost containment and system improvement. The budgets we've submitted to you reflect that commitment. Compounding your difficult task of cost containment is the fact that healthcare costs are not evenly distributed in Vermont, but the burden of cost increases fall disproportionately on Vermonters who are commercially insured. Our net patient revenue requests represent the needs of our community's growing and aging population, as well as our network's focus on increasing patient access to care. Our commercial rates reflect the cost of providing these needed healthcare services. That means the commercial rate requests before you are solely what we need to cover cost inflation. As I mentioned earlier, the burden is mostly borne by commercial ratepayers, as Medicare and Medicaid do not keep up with increases in cost inflation. An exception is critical access hospitals, which receive cost-based funding from Medicare and therefore don't need to request the magnitude of commercial rate increases that the PPS hospitals need. This is a long-standing structural problem that has real impact on Vermonters and the hospitals that serve them, and I hope we can continue to work together to address this. I've been in the job now for 9 months. In that time, I've learned a lot about healthcare delivery in Vermont and Northern New York. It's been both humbling and inspiring. It's humbling because I see the critical role our organization plays in the lives of people in our region, as a provider of both acute, complex academic medicine and safety net services. It's inspiring because I've met so many people across our system who are truly mission-driven and dedicated to improving the health and lives of Vermonters and New Yorkers. The people of the UVM Health Network are dedicated to changing how healthcare is delivered, organized, and paid for, because we all see the need for meaningful reform in these areas. I hope you realize that it's unique to have a healthcare system and a state government aligned on these fronts. As a newcomer, it feels like a real and exciting opportunity. And in fact, it's one of the reasons I took this job. Over the past year, we've worked hard to focus on the things we can control in order to strengthen our workforce, increase revenue, and find new efficiencies. This work has improved patient access to critical services like surgery and radiology. But serious and ongoing healthcare cost pressures are not unique to Vermont. We exist in a national healthcare economy where the costs of recruiting doctors and nurses amid a severe workforce shortage and the costs of new equipment and new drugs are very much outside of our control. I know last year's budget process was difficult for you as regulators, and it was difficult for our health system. We faced unprecedented cost inflation and requested unprecedented commercial rate increases. Our cash position was severely depleted in FY22 due to the staggering cost of providing care and poor financial performance. We appreciated the board's willingness to recognize the circumstances hospitals were facing in FY22. I wish I could say this year was significantly better. Unfortunately, healthcare cost inflation hasn't entirely abated, even as we've seen national news stories about general inflation returning to more quote-unquote normal levels. Our expenses continued to rise for the remainder of FY22 and during FY23. We're currently about $90 million over budget for cost inflation for FY23. However, none of that $90 million is included in our FY24 request. We project additional cost inflation from 3.3% to 5.2% for FY24. I am happy to report in the past year, we've been able to reduce our reliance on temporary labor, which was the biggest driver behind last year's budget request. But we're still relying on far more temporary employees than what we would consider normal, at a far higher cost than we pay for permanent employees. Since October, our full-time traveler numbers are down by nearly 100 across our network, and traveler expenses have declined by about $3 million per month. Additionally, the rate we pay for travelers has declined by 35% since the beginning of FY22. Our continued use of these travelers is primarily to maintain the critical access and care our communities need, but this is not sustainable without continuing support from you. Our dedicated people are also our largest cost. Over 60% of the network's expenses are salaries and benefits for employed staff, travelers, and physicians. As we're experiencing both a regional and national workforce shortage, these labor costs are largely outside of our control, while we focus on maintaining access to necessary services. The simple reality of operating a not-for-profit health system means we must take in enough revenue to cover the expenses of providing patient care. And just as importantly, we need to invest back into our people, equipment, and facilities. We have no stockholders or investors. Every dollar that comes in supports our mission. Financial experts and lenders expect a financially healthy system to have a minimum of 2.5% margin. Our budget requests include margins of between 1.5% and 3% for our Vermont hospitals. FY24 is just one step forward of what we ultimately need to achieve in our network's operating margin to be a sustainable health system for Vermonters. The poor financial performance of the last few years has resulted in our need to remove or delay over $100 million in reinvestments across our network. Make no mistake, continuing to kick this can on these capital investments is having a mounting impact on access for patients. The budgets we've submitted for our 3 Vermont hospitals are designed to 1, protect essential services, 2, invest in innovations, service expansions, and critical functions for our future sustainability, and 3, minimize the cost impact on consumers. We recognize that this is a delicate balance. We can't ignore the need for investments in plant and equipment and important initiatives such as our Population Health Services organization. These investments are essential to our future success in providing high quality, equitable, well-coordinated, and efficient care. As we begin today's meeting, I ask that all of you keep in mind that we are a not-for-profit rural healthcare system serving an area of more than 1 million people under very challenging conditions. Our patients need us more than ever before. We're seeing more people with more chronic and complex healthcare needs than we ever have, and we anticipate this need to grow more acute in the years ahead. We know we're not alone in these challenges we face. Across the U.S., more than 150 rural hospitals have closed since 2010, and many more are struggling today to provide essential but money-losing services such as mental health care and labor and delivery services. Here in Vermont, we're fortunate that we can have a transparent public conversation about how much healthcare costs should increase. But it's also important to have a public conversation about what our patients need, the challenges we face, and analyze the consequences of cost constraint. Are consumers seeing major access barriers? Are we deferring needed upgrades to facilities and equipment that our patients need? Are we driving people and our patients out of state to seek care? We look forward to a healthy conversation with you about how to best contain healthcare cost growth without compromising or harming the services our patients and communities depend on. Rick Vincent, our Chief Financial Officer of the UVM Health Network, will now share a few remarks. And then later, during the question and answer portion of today's hearing, Rick will help keep us organized and lead our network's response, and will call on his other colleagues as needed. Thank you very much.
Thank you, Sunny. Good morning, everyone. Before today's review of our FY24 budgets gets underway, I'd like to thank Director Sarah Lindberg and her Green Mountain Care Board hospital budget staff. Our network team has always very much appreciated Sarah's collaborative approach, always taking the time to meet with us, discuss issues, and work toward our common goal of having clear, understandable, and actionable information. We hope the great work she has started in making the budget reviews a more data and metric-driven process will be used by her successor as a base for continued improvement. Sarah will certainly be missed. We wish you the best of luck in your new role, Sarah. As discussed in our budget narrative, our FY23 year-to-date performance shows that we are slowly starting to recover from years of stark financial uncertainty brought on by the pandemic. Our FY24 budget helps us to continue to emerge from the pandemic's lasting impacts of extreme burnout of our nurses, physicians, and staff, a severe labor shortage, national hyperinflation, lack of capacity throughout our state for adequate post-acute mental health and substance abuse treatment, access to care challenges, and the ever-growing need for healthcare services in our communities due to our aging and growing population. The UVM Health Network continues to focus on our operational efficiency. A key evaluation for the UVM Medical Center, the largest partner in our network, is how we compare on a total cost basis to other academic medical centers in the country, such as the Association of American Medical Colleges Council on Teaching Hospitals and Health Systems quarterly survey. Over the last 3 years, the UVM Medical Center's expense per adjusted inpatient day has hovered around the 25th percentile, benchmarked against other teaching hospitals. Another evaluation of operational efficiency is how the UVM Health Network compares on administrative shared services. In our response to the Green Mountain Care Board staff on August 1st, we highlighted how we compare to Centellus benchmarks, which includes over 200 healthcare organizations throughout the country. Compared to that benchmark, the UVM Health Network is at the median for administrative shared service costs as a percentage of total costs. Being at the median shows great progress for our relatively young network, but we still have work to do to become more efficient. Through continued standardization of our systems, the use of robotic process automation, artificial intelligence, and other technologies, we will become more efficient. The budget review tool has attempted to get at operational efficiency performance through the administrative and general salaries to clinical salaries ratio. We highlighted in the August 17th letter sent to the board that there is an issue in that calculation as it relates to the UVM Health Network's administrative shared service costs and how they are accounted for in the cost report data. We hope that explanation and the adjusted calculation we provided, which puts the UVM Medical Center within the benchmark range, was helpful in understanding that issue. The UVM Health Network has detailed our continued efforts to increase patient access, optimize our capacity, and strengthen our workforce, especially through professional development and advancement programs for current and new employees. Our FY24 budget as submitted will help us build financial sustainability into the future. As CFO, I'm extremely focused on the work within our network's control to stabilize our finances. I'm also deeply concerned about the financial impacts outside of our network, which are outside our ability to control. In last month's economic review and revenue forecast update prepared by Cabot, Rockler, and Associates LLC for the state of Vermont and Legislative Joint Fiscal Office, the report noted key reasons why it has been so difficult to hire permanent staff. The first is the record low unemployment both nationally and in Vermont. In June, the Vermont unemployment rate was 1.9%. It's hard for us to recruit and retain locally at that rate. Good news on that economic indicator, which boosts tax revenues and reduces public program expenditures, is bad news for us as an employer. Another factor making it harder for us to recruit regionally and nationally is Vermont's real estate value increases. Home price growth in Vermont is starting to recede from the highest rates we've ever seen, but prices remain far above normal pre-pandemic experience. We know that finding available housing is a major hurdle for people interested in joining our health network team. In the Burlington MSA, house pricing growth is still 68% higher than prior to the peak. In late July, we shared with Director Lindberg our credit rating agency's recent actions and commentaries regarding the UVM Health Network. As we have detailed in the last several budget submissions, our network's 5-year financial framework uses rating agency A medians to establish financial metric targets, which is an objective representation of a financially stable health system. Over the last few years, the rating agencies had been clear that if the network did not start generating an operating EBITDA margin of 7 to 9% and begin to replenish cash reserves, we would receive a rating downgrade. As we had alerted you, Fitch Ratings downgraded us from A+ to A in June of this year. Credit ratings are an indicator of long-term sustainability, and our network team takes this rating downgrade seriously. Despite our recent financial challenges, our rating agencies maintain high confidence in our organization and our long-term strategy. This past winter and spring, when board discussions of the upcoming hospital budget process and the FY24 hospital budget guidance began, there was a great deal of conversation about the 2-year 8.6% NPR guidance for FY23 and FY24 combined. We clearly shared our opposition to the board's continued reliance on that approach. During those discussions, and again later in the spring during the board's meeting to discuss VAS's reconsideration request of the FY24 hospital budget guidance, the board reiterated that the continuation of the 2-year NPR guidance was to create continuity over FY24 and FY23 and FY24, and that hospitals should submit the budgets they need for FY24. In the May 31st Green Mountain Care Board meeting, a quote from one board member: "If a hospital's budget exceeds the NPR FPP growth guidance, the board will review the specifics and support for that NPR FPP growth provided by the hospital in its FY24 budget submission using the factors and criteria set out in this guidance." Hospitals listened, and the FY24 budget submitted to the board on June 30th reflect the difficult work to build accurate budgets reflective of our community's needs and the access to care that Vermonters deserve. In the insurance rate review decisions and orders that were posted on the board's website on August 7th, the board wrote that insurers should assume the board will reduce hospitals' requested commercial rates by 50%. We are not aware of any basis of fact or reasoning included in this broadly made assumption. We do not understand how the board could have already decided that they will have hospitals' requested commercial rates before any hospitals had yet participated in the August budget hearings and before the board had deliberated on those budgets in September. We hope that assumption has not already been made and that we can count on your partnership and collaboration in this year's budget review process. Our FY24 budgets paint a realistic picture of what is needed to care for our patients today and into the future. We look forward to our continued work together to balance Vermont's healthcare cost growth and the solvency and sustainability of Vermont's hospital system. Thank you.
All right, thank you very much. I will figure out how to share my screen. So when we restrict this, so we'll just be focusing on UVM Medical Center initially. However, I suspect that some questions may be network wide. So we'll be kind of trying to cover those along with the UVMMC results. So we see that for UVMMC, they are showing the highest NPR growth from fiscal year 22 to 24, as well as the highest operating expense growth at 15%. I think you spoke in your opening statements about some of the challenges in these operating expenses. And I'm just curious, what about your status as the academic medical center do you think specifically is different for the operating expenses growth that you're facing compared to your other Vermont colleagues?
Thank you, Sarah. So I'll get started, and I'll probably I'll pass to a few people too to just add, probably Steve. So the one thing I think that makes the UVM Medical Center obviously unique compared to other partner organizations is that we take care of many more complex patients than we do at CVMC and Porter. We offer a much wider diversity of services. Those services that we offer, particularly the very high-level tertiary and quaternary care services, are costly services, so they certainly will impact the cost growth more than what we would see at CVMC and at Porter. Steve, anything you want to add to that?
Thank you, Rick. So I would add that during the pandemic, when it was very difficult to do so, we opened multiple additional beds to care for Vermonters who needed us at great expense, mainly staffed with travelers. And we still have many of those beds open because Vermonters need us. We also provide dialysis services across the state of Vermont. Our partner hospital, academic medical centers in other states are not taking new dialysis patients right now at all. Adding to the great challenges, a couple of our dialysis clinics are almost 100% staffed with travelers. But trying to reel those services in is impossible because it's keeping those people alive. Our budget increase has a lot to do with improving access to care. We've done tremendous work this year to improve access to radiology services, but a lot of that is by paying our people double time, overtime, Saturday clinics. And the same with the OR. We've made a major push this year to have our OR catch up on the backlogs. And we've done a lot of that by bringing in travelers to help us and by paying overtime and special pay. So our operating expenses are driven by increased access and utilization and caring for populations across the state. Thank you.
Got it. So I think when I look at your operating results over time, you mentioned it's a pretty historic ask, and we see that we're not seeing a lot of change to margin or the cash reserves. And I sorry, I don't have my notes in front of me. I think it's on page 27 of the narrative. It says that this is a small step towards kind of this recovery process. And I know that we're only talking about a fiscal year 24 budget today, but do you expect that these historic asks are likely to persist into future fiscal years?
So we thought certainly this year that the ask was going to be lower than it is. Unfortunately, the continued use of and need for contract labor, as Steve highlighted, we're doing it for the right reasons. We're doing it because we're trying to maintain access, trying to serve all the needs of Vermonters. As the tertiary and quaternary center for our region, we support the Vermont healthcare system in a very unique way, and for us to continue to provide that access definitely generated a much higher cost this year than what we were anticipating. As Sonny shared in his opening remarks, even with the significant increase that we very much appreciated last year, we still are $90 million over our cost inflation estimates this year because we have maintained all that access that that we feel that that we need and that Vermonters need. Going into future years, I think two things. One, we are starting to see inflation subside. We definitely are seeing that nationally. For us as healthcare providers, what the key there will be seeing a decline in that contract labor utilization, which we have started to see both in terms of full-time equivalents and the rate that we pay for contract labor. We're seeing a fairly significant increase in, or at least we will see when new grads come off orientation here in the next couple months, we should see a pretty big decline. And maybe I'll ask Carrie to speak on that a little bit. So the anticipation, I think, is that cost inflation will start to subside, and we're definitely working hard to impact that where we can, so that rate increases don't need to be as large in future years. And two, I do think we still do have some government rate opportunities that could reduce those rate increases in the future. I think we talked about that a little bit during last year's hearing and some of the pursuits that we had in that space to keep commercial rates down. And I think we still have some opportunities there to impact that. But maybe Carrie, if you want to talk a little bit about the work that we've done to try to reduce our reliance on contract labor and some of the positive signs that we see hopefully in the next couple months.
Certainly. Good morning, everyone. This is definitely the time of year that we see a bolus or an increase in registered nurses coming out of school and transitioning into practice. So at the University of Vermont Medical Center, we have over 120 graduate nurses that are in the process of onboarding that will help the workforce challenges that we're facing with contingent labor. So it is a process. And having those folks come on board are critical to sustaining the way we deliver care at University of Vermont Medical Center and all of the facilities in the state of Vermont and upstate New York. There's the recruitment piece, which that's a part of. We are working really closely with our academic partners to understand what this year looks like next year and future in order to anticipate workforce needs and partner closely to ensure that we are aligned related to the work we're doing and helping bring people into our workforce. In addition to that, we're working really closely with our own teams to understand where people that are employed in all of our facilities are interested in growth so that they can grow within the facility. So what that looks like is investment in individuals related to surgical techs and LPNs and RNs and all of those things so we can support our own teams staying within our organization and growing to meet the workforce challenges. We have worked really closely with our teams to understand recruitment, but we're working equally closely around retention because that's a critical piece. We want to bring people into the organization, but we also want people to stay. So what that looks like to me is understanding the practice environments and looking at ways we can help support people find meaning and purpose in their work and satisfaction in their work. Some of the ways we're doing that is looking at programs like Pathway to Excellence, which outlines standards that are benchmarked and places across the country are utilizing. And we are working in that direction with all of our facilities in the network. And that is going to take us time because we have strengths, but we also have some gaps that we're working to close. That I think will help us with the retention piece. And again, that's going to take us time. So I feel like this year is a building year to help us move forward. And we have targeted strategies to reduce travelers or contingent labor. And we will continue to do that with our goals associated with recruitment and retention. Happy to answer any questions, but hopefully I covered that.
Yeah, thank you very much. And that's probably a good segue into the labor piece. So we do see, and I think there are more than enough that, so there's quite a few union negotiations that are likely to keep this trend kind of extending upward. If we use the 17 cost per FTE and trend it forward, we see that, you know, you're north of that through fiscal year 22, and I suspect with some of this additional labor expense in the immediate horizon, that trend will continue. So I have real two questions about this. You've really hit about what you're trying to do to help improve recruitment and reduce these expenses. But I'm also curious about, you know, how you kind of factor that in when we think about the Vermont-wide workforce. We know that, you know, the rates that UVM is paying and that you're kind enough to post in some cases can affect the market. So I'm just curious kind of how you think about how to balance that given the shortages across the whole delivery system.
Thank you, Sarah. So I'll get started, and again, I'll pitch to a couple folks. So one, I think just to make a point on one of the items you raised that may be driving this up, Sarah, which is union negotiations. I think we want to be clear that actually that our philosophy is to pay all our staff at an appropriate market rate, and we don't view union negotiations necessarily having an outsized impact on the rates that we pay. We try to be very consistent in that approach, in that we're constantly looking for where our staff are compared to the market. And we essentially treat that, and our philosophy is we treat that equally, whether you're represented by a union or not. You know, we're constantly looking at that data. In terms of where this is headed, you know, even what you're describing in terms of the impact that we have on the greater Vermont wage base, we actually find in some of the roles there are other industries in Vermont that are actually pushing us. So I think it's happening in multiple directions depending on the roles. I think that we'll find as well that, you know, the benchmark data, particularly with the significant hyperinflation that we've seen, that it's going to take a while before the benchmark data actually, you know, catches up with what's transpired over the last year or two. So with that, I think the presidents are probably able to kind of round out our philosophy and where the impact that we have on the wages in Vermont. So I'll start with Anna.
Thanks, Rick. Good morning, everyone. So just to put a finer point on what Rick has already mentioned, we are committed to staying competitive in the market. And a reminder that our market isn't just the state of Vermont, it's also regional and in some cases national. And so we are committed to staying competitive. Why? Because we really have to maintain the services we're providing. As Rick has mentioned, we are using a lot of contracted staff. I don't see that changing. I'm a nurse. We saw this nursing shortage for years before the pandemic, and it certainly was accentuated with the pandemic, with the great outmigration of individuals from healthcare. To add to what I've heard my colleagues say around workforce pipeline programs, I think our strategy to build those programs, which at CVMC we started in 2018, and we've graduated over 98 LNAs and almost as many LPNs, RNs in that period of time, is to really grow our talent locally. I think that's critical, but we need a partnership in that space, not just within healthcare, but across the industry. To Rick's point, with our entry-level positions, our market is not just healthcare. We lose people every day to other industries in the state of Vermont. The housing shortages are impacting our market as well as the ability to have either daycare or elder care, depending on what phase of the life continuum our employees are in. So a number of challenges in the workforce shortage space, and we're hoping to continue.
Ms. Noonan?
Yes.
I'm sorry to interrupt. Dr. Merman's been recused from CVMC. So if you guys don't have an objection to him participating in this and hearing this, that's fine. But I just wanted to flag that he, this seems CVMC focused. I just wanted to put that out there. It's your choice. If you don't have an objection to it, fine, but
I think my comments in this space are generic. There's some specificity to CVMC that Dr. Merman is well aware of. So I'm comfortable continuing just sharing the comments related to market unless
Great,
there are
thank you.
other objections. Okay. So again, just wanting to round that comment out by saying the market is driven by a number of factors, and all of those we're working on to broaden the perspective. The programs we started at CVMC are now being embraced and across the UVM Health Network. So those programs are serving as launch points for the similar programs across the network, again, to address the pipeline issues, workforce pipeline issues that we've experienced. Thanks.
Thank you, Anna. Sorry, I actually lost track of the fact that we were doing this in order too. So sorry that I called on you, Anna. But if it's okay with the board, there are some instances I think that it would be helpful to get other presidents' perspectives on this as well. So
Rick, this is Sunny. I just thought I'd just respond to Sarah's maybe question more globally. I think you're right, Sarah. I think whenever there's a union involvement at a very global level, wages and costs go up. Those are going to increase our healthcare costs. We just think it's the cost of doing business in Vermont, but that's the reality, and I think that's what you were getting at. And we try to anticipate that because and I'll just echo what both Steve and Rick said, which is that we try always to pay a very fair wage. That's a market wage. So we don't anticipate that those increases that come will be significant because we're already there, but you're right.
Okay, anything else you want to comment on for this topic before I scoot along?
Steve, anything you want to add?
Thank you, Rick. I'd like to make a couple comments. So UVM Medical Center is in the midst of negotiating our first contract with our support staff right now. We're hoping to have that contract done by October, and we will restart a new contract negotiation with our nurses in January of 24. So we do have two big upcoming contracts. I will tell you that it's in the best interest of the medical center and our employees to have fair, strong contracts. It helps us with recruiting. It helps drive down traveler numbers, and it's predictable. So I think the major difference between negotiating with a union and keeping everyone at market is the union people we negotiate for typically 3 years, and we get them to market in the start of the contract and then give them predictable increases over the next couple of years to help manage what our costs would be out in the out years, 25, 26, and so on. For our employees that are not in the unions, we adjust in real time, but our philosophy is the same, to pay everyone at market. So I really see it as a difference of predictability, but fair, strong contracts are good for our staff, they're good for the hospital, and so they're good for our patients. And so we will continue to work hard with our unions, who are our employees, to have good, strong contracts. Even when it's difficult at parts in negotiations, at the end, it's good for all. And the last thing I'll say, Sarah, is that the cost of everything is going up right now. And we hear from our employees all the time that the bagel shop down the road is paying more than some of our food services staff. And so we have to have a wage that is competitive to have enough people here to do the work that we need. So we're not using expensive travelers for that work. Thank you.
Thank you. And when I move here, just kind of again, forgot what screen I'm operating on, pardon me. When we look at the changes, I'm a nerd, I call it the covariance, but how utilization, adjusted discharges are changing as compared to operating expenses and net payer revenue, we see that the operating expenses from 21 to 22 really shot up, but utilization was, more in line with like kind of a typical pre-pandemic craziness amount. And so I think you've talked to, why that trajectory is pointing that way. Just want to give you an opportunity if you want to flag anything else about that growth and where you're thinking of it for 24 and beyond.
Yeah, I think Sarah, we hit on that fairly comprehensively, both in what Steve shared and the fact that as the tertiary and quaternary and safety net hospital for the region, we've maintained a significant amount of access for both services, for transfers, and Steve can probably talk a little bit about transfers as well, that we haven't always been able to meet the needs there, even with all the increased costs that we've incurred. So that trajectory is certainly due to us trying to fulfill our mission of being there for Vermonters. Steve, I don't know if you want to say anything else. I think you hit on these fairly well earlier.
Sarah, when we presented our budget update in December of 22, we told you that we were declining about 5 patients a day for transfer. And since that time, through a lot of work on access and improving accessibility, because that's been a major focus of us over the year of 23, I have the data. And in July of 23, we declined 68 patients total compared to 159 in December. So about a little over 2 per day. And most of those patients we may decline on Thursday night, but take them Saturday morning. They're not permanently declined. So we done a lot of work to improve access. We still have great challenges with getting people discharged in a timely fashion. Every single day we have between 30 and 50 people here who are ready for discharge. So that drives up the cost of care, but we're not being reimbursed for that care. But we have done a lot of work on that. Thank you.
Okay. And then Burlington HSA and the University of Vermont is going to look very different in these indicators. You're a tertiary care facility, so we see, quite a few discharges coming from outside your HSA. We also see, one of the highest proportion of commercial patients in the Burlington HSA, and we see that a heavy proportion of those dollars are staying within the HSA. I know that you've raised some concerns about the completeness of the all-payer claims database in reflecting this accurately. And I was just curious about the populations that we're missing, which are going to be out-of-state patients and those who have self-funded insurance. What you think might be different about who we're missing that would change some of what we see without them.
You're asking that question, Sarah, in terms of the context of how this compares to other hospitals, or?
So I'm only going to see Vermont residents, and I'm missing a fair portion of the self-funded market, and I'm not seeing the folks that are coming to you from out of state. I never saw people without insurance or, federal employees, military. When I look at VCure's pre and post Go Bay, which is when we lost the self-funded market, it looked like the PMPM of the population left went down, and that the utilization rate went down substantially. So I totally buy we're missing a bunch of, what your records are going to show. So I'm just wondering how you think any VCure's results might be different if we had a more complete sample of the claims. Like, what is it about the out-of-state patients and or those with self-funded insurance that you think might be different or that we might be missing in that data set?
At least one thing I think that we've seen is that the out-of-state data would show a higher acuity of patients if they're coming here from out of state. That's when you're looking at the patients that essentially are around the UVM Medical Center. Again, the UVM Medical Center is unique in that it's both the community hospital for the area, and it's the tertiary and quaternary care referral center for the region. And so the out-of-state data, that's one thing I think that you would see is higher acuity if that was included. In terms of the self-insured business, probably might, we might actually have some experts here on the call that can chime in on this, but I don't anticipate that would have a significantly, I don't think it would paint a significantly different picture than what you're seeing here. I don't know if there's anybody else that wants to add anything.
Rick, this is Kelly. I can just add, if that's okay with you.
Absolutely.
Sarah, I think you hit on the out of state and what Rick just said, the tertiary. We do serve, out of state, New Hampshire and New York Medicaid, along with other Medicaids. So that would certainly influence the picture here. And again, that could be, we have had mass Medicaid for, various reasons of requiring tertiary care here. So it really depends on people who have migrated into the state and the coverage they've maintained, either traveling or, again, our close partners. So I do think the out of state would create a different picture.
Okay, thank you. So we talked about this ratio, and you have a robust response about kind of what you think.
Sal, this is Tom Walsh. Sorry to speak out of turn for a moment, but I wanted to just ask you a couple questions about this tool, if I could. The data that it's displaying is the data that we said we were going to use during our guidance. Am I understanding that correctly?
Yeah, everything in here was in the guidance. Yep.
Yeah, and there's no analysis that's going on here, right? There's no t-tests or ANOVA regression or algorithms being used to analyze any of these data. This is a display. Is that
correct?
Also, yeah. So we could have done this is box plots with whiskers. We could have done bar charts. We could have done tables. It's just a means of displaying the data that we said we were going to use. Is that correct? Yep. Okay, thanks.
So when we look at the academic medical center compared to the list of associated medical colleges, we can also further filter that. So we're just looking at rural facilities that were included in it. Of that subset. We also made sure to add all of the comparators that UVM identified. I believe there were 12 other hospitals that were in the unique position of being both a community health facility and an tertiary, advanced academic medical center. I'm just curious, why you think that's such a rare situation, or how you approach that when you don't have a whole lot of people to compare yourselves to. Like how you kind of approach that when you're trying to, see how good a job you're doing on stuff.
Yeah, it's difficult, and the way that we use the data is we look at, obviously multiple sources to try to triangulate around how we're doing in certain areas. So we shared with you the Centellus data, for example, in terms of administrative shared services. CMI, that we use Vizient data to essentially try to give us a sense on where we're at. We've had external evaluations as well, so not relying just on kind of static benchmark data that's out there, but actually have somebody, have an organization come in and tell us, is our CMI appropriate for, just as an example, is our CMI appropriate for the acuity of the patients that we have. And so we triangulate using multiple pieces of data. The CMI is one that we know. We included a little bit of detail in this in our response, that we know that we've struggled in this area for some time. We're always going to look, the UVM Medical Center is always going to look lower than a pure academic medical center that you would find, in Boston or New York, that has outlets for their non-acute patients. They have outlets because they don't also serve as the community hospital for their for their region. So CMI is always going to look lower for the UVM Medical Center because of the unique role that they play. But we've, through benchmark data, through engagements, we know that we're below where we should be in truly representing the acuity of our patients. Is just, again, just as one example. We've tried to improve in that area to truly reflect the acuity of our patients through education, through process improvements, through many different factors. But the key thing that will change for us is the system. Actually, we just finished the 2-week implementation last week, which is iodine, which is going to be a significant game changer for us, which when we started down this path pre-pandemic to improve in this area, we had seen that most of the organizations that had higher CMIs, particularly academic medical centers, had some type of data mining system that they were using to kind of reduce the reliance on a human being combing through reams and reams of EMR data to truly document the acuity of the patient. So that's, again, just as one example, we don't rely on one sole piece of data for to determine how are we doing in this in areas. Rating agencies, for example, we use those that tell us how we're doing financially. So we use multiple sources to try to highlight the improvement opportunities that we have. I see Sunny's off mute, so you must want to say something.
Yeah, just a couple of things, Sarah. I think clearly our CMIs are not a real representation of the complexity of our patients. That became obvious to me as I walked around University of Vermont Medical Center and I saw the coding. We've actually brought in some consultants that I've used when I was in Boston. They've taken a preliminary look, and we're going to really truly implement this moving forward. So they really expect the CMI to go up as we more accurately document and capture the complexity of our patients. So the question is, how much will it go up? I don't know, but we're going to find out over the next year. So I think we as an organization have been reticent to put dollars into capturing the coding better, but it is important. It doesn't change care. It just better captures our complexity and our reimbursement, so it's important. The other thing is, having worked in academic medical centers in Boston again, that were situated right in the heart of the city, yet we're not the community hospitals in those areas. The University of Vermont Medical Center plays a really unique role in doing both of those. And so we see the reflection of that as well.
Rick, can I add one last? Can I add one last thing? So thank you, Rick and Sunny. What I would add, Sarah, is that we participate in the Vizient database, which basically is all the academic medical centers across the country on their quality and safety database. And there are other peer academic medical centers that are similar to us. There's no two that are exactly the same. And so for issues that we track, such as, I'll just give a quality one we've been working on. How many patients are transferred to the academic medical center and then die within 24 hours? Because you could make a case that maybe those people shouldn't have come. All rural academic medical centers that are in our group have a high rate of that because we're typically surrounded by small hospitals without a lot of resources. And the patients who are very sick would like to get a consult by neurosurgery or the cardiologist or something like that. So those patients come here, get an evaluation, and then oftentimes they're determined that we can't do anything else. We're trying to figure out ways through telemedicine and through our transfer center to help keep those people local so they don't have to go undergo that transfer. We're working with our partners across the United States on issues like that, on issues like case mix index, on issues like how to make sure that we can be both the local community hospital and the academic medical center. I will say, as a practicing physician for 30 years, I always loved the fact that we were both our community hospital and the academic medical center. It makes us very special. And I think it's one of the very unique things about the UVM Medical Center. Thank you.
Sure.
Can I just go back to Tom's point?
Yeah, sure.
Because I might have been confused. And this is like an internal question, and if I shouldn't be asking it, you should just tell me to be quiet, Rick or somebody else. When did we actually get the guidance that we're seeing today?
It was adopted in March of 2023.
And so we got the guidance in March of 2023.
Yep.
Yeah,
I
the
hadn't seen
data
it before.
Yeah, this actual tool, I believe, was put out on, was it August, sometime in early August, right, Sarah, in terms of the actual data that was behind the guidance that was created in March.
The summary display here. Yep.
All right, that. Thank you, Sunny, and good morning. But that is my point. This is a display. We could have shown just a table. We could have done pie charts or bar charts. This is a box plot with whiskers, but it's the same. So there's no change in what we asked for in guidance. It's just the way that Sarah, being Sarah, figured out a cool way to show the data. But there's no new analysis that's going on.
And Rick, if I could jump in, Member Walsh, we strongly disagree with that characterization. The data that sits behind this tool was presented to us for the first time on August 1st, and we don't believe it conforms to the guidance that was adopted in conformity with the statute and with the rules back in March. We did not intend to spend valuable time during the budget hearings debating this issue, but having been raised, we do feel it's necessary to put on the record our view of this tool.
I understand the point you're trying to make. This is simply displaying the facilities we said we were going to display.
It isn't, but I'm not sure, again, that it's valuable for us to have that debate here.
Fair enough.
Okay, and so in Exhibit 9, I believe it is, you list a CMI of 1.8. I presume that is for the full patient panel, whereas this would be just Medicare. Do I have that correct?
I believe that's correct, Sarah. I don't have the numbers in front of me.
Okay, I guess my question being, do you translate the commercial severity into a Medicare MSDRG to get that CMI, or because I know that not everyone pays that way commercially?
Yeah, we definitely do calculate an overall CMI for all of our patients. So yes, we do a calculation to get to that CMI for all patient groups. Okay,
thank you. And then, as you already discussed, there was a substantial change in your cash position between the fiscal year 21 and 22. And I'm just, if you could speak to kind of how you evaluate the use of cash resources when times are lean like this, what goes into that kind of decision-making process for you?
So the biggest impact there has been in our capital spend. So this really started at the beginning of the pandemic, where the capital approval and request process was completely centralized. So historically, the way that we've managed capital is we've created allocations for routine capital that each partner organization would have, and they would make their determination with some guidance from leadership on how they would prioritize the needs. But as long as they stayed within their allocation for that given year, each partner was allowed to spend within that pool. When the pandemic started, we had to centralize that process so that every capital request, no matter the size, had to be reviewed centrally to ensure that we could truly afford to proceed with that capital purchase. What it's done, and all of that was in reaction to try to conserve our cash and try not to have it drop below where it already was. what that's done is we focused on really the break fix items. So if something was getting old where it was, on the verge of potentially failing, or safety needs, those types of things, that has been the focus of ours for the last few years to try to keep this cash balance from going down any further. So Steve spoke to that, a little bit in his remarks. And it's also, you see the impact of the dynamic of that backlog of capital that we built up over the last few years. When you look at our financial framework, even though if our budget is approved and if all our other assumptions hold true, and we're able to generate an operating EBITDA margin close to 7%, you can see that in the first couple of years, so 24, 25, cash really doesn't grow by an amount that you would expect it to grow if you're generating that kind of margin, because again, we've got to address this backlog of capital that has been built up over the last few years.
Okay, and so the next exhibit has to do with cost coverage. So for UVMMC, we see, after these are adjusted with Vermont all-payer relative weights, we see, some relatively higher coverage of the Medicare allowable costs for outpatient versus inpatient services. See some noisiness around the Medicare reimbursement, and we would expect, I think, with the new Seoul Community Hospital designation, that outpatient line would get a little closer, go north a little bit with that 7% bump on that. And then again, this decline on the cost coverage from Medicaid is on that downward trajectory. You did spend time in your narrative, commending them for the rate increases they were able to realize for this year. So we appreciate you reflecting that in your budget. So, as you've said, you don't have a whole lot of comparators, but we do have somebody next door. We have Dartmouth has a higher relative payment and a higher relative cost than you for the commercial population. So that's, in my judgment, probably due to the limitations of our data set. We're getting the people that travel to Dartmouth for the acute care, and we're missing the people that are coming from New York to get that acute care. So we would say that, that's probably part of what makes that comparison tricky. However, I think in this point is made quite clearly that that Medicare payment on a per case basis is much higher at Dartmouth because they have the higher wage adjustment historically and some other differences in their Medicare reimbursement. So we do see that your relative cost coverage is lower. We do have some suspicions that the all-inclusive population-based payment might be making that look a little more dramatic than it likely is. So that it's in there, but I don't think it's all in there. And then again, for Medicaid, we actually see a higher reimbursement at Dartmouth per discharge. Again, that's probably measuring acuity versus anything else. However, on the outpatient side, we see that your costs are lower than Dartmouth substantially, in that your payments are a little bit higher. Seeing a little bit more apples to apples. Again, with that Seoul Community Hospital bump, I would expect this payment to get closer to the cost. And then we see, again, similar values between you and Dartmouth for the Medicaid population. And just to click over to the RAND data on this topic, I did add a...
I'm sorry, Sarah. I'm sorry, it's Tom again. If we could look at the Medicare again for a second. Yes, the wage adjustment is different for New Hampshire because of its proximity to Boston, but probably the biggest difference is the difference in teaching payments as a component. That's based on the size of the medical school, and Dartmouth's medical school and teaching component at their hospital is just much larger. So they receive a bigger payment from Medicare for that. Just want to be clear about that.
Okay.
And is it is it possible to look at the actual cases? The differences in the kinds of cases that go?
Yeah, we have a lot more detail that we have it for grouped by DRG and by APC for certain services. If that's helpful, we can look at that. We did look at it back in October of 21 was the first time we did this analysis.
And were you able to see differences in the kinds of cases? DRGs.
Off the top of my head, I wouldn't trust my memory, but I'm happy to kind of share the complete data set.
Yeah, I mean, I think that goes back to when Dartmouth can provide the care that they can see where there's value for their providers in reimbursement. So it's not unusual for other hospitals like the Brigham, for example, to have more physicians and more services available for the cases that they can make more money. If you don't have to provide for the whole community, then you can pick and choose where you're going to have availability. It's a difference between what University of Vermont Medical Center has to do in taking care of everyone and specialty hospitals or consult hospitals that can kind of tailor what they're going to have available. I'm not implying that Dartmouth is deliberately doing that. It's just the nature of when you're not having to cover everyone, what you're able to do. So I think it's really important that when we make comparisons, that we really have to look at the specifics.
Yeah. Thank you, Sonny. I think it's a point well taken. And the point I was trying to make was simpler, that the Dartmouth Medical School is larger. There are more students, there are more residents. And the adjustment that Medicare makes for teaching facilities, the additional money paid per discharge for teaching is higher the larger the school. So because Dartmouth Medical School and the resident has a greater number of residents, greater number of students, its payment from Medicare will be larger. So it's not just the wage component that's been talked about, but there's the teaching component, and that's where that comes from.
Fair, true, sorry, absolutely right.
Yep, great.
And so the RAND study has, more national coverage from their sample, and we did add the teaching hospital filter and so when we do that, we see that University of Vermont is at the median from 2018 to 2020. Dartmouth is kind of between the 25th and 50th percentile, but very close. However, on outpatient, we see that Dartmouth is in a similar range, close to the 25th percentile, and UVM is above the 75th percentile. So I just had a couple questions. One is, we've heard that the Green Mountain Care Board has been substantially limiting the amount of commercial rate that the hospital feels like it should get, but I would expect if that were true that you'd be lower on this distribution, have a lower relative reimbursement. So I just was curious if just curious what you'd say about that.
Yeah, so in getting into this data, Sarah, to be honest, I'm a little bit kind of over my skis here. So I don't know if we've got the experts that have really dug into this to understand the data a little bit more closely. And even if commercial rates are lower in Vermont, we don't know. It's hard to tell exactly what that data tells. So I don't know if we actually have anybody on the. We have somebody on our team that really kind of dug into this data. Let me just see if there's somebody on the. Actually, we might have to get back to you on that one, Sarah. Sorry.
Okay, and then as part of the findings and rate review, at least for 21 to 22, it looked like the Vermont hospitals got twice the rate of the non-Vermont hospitals. So I would expect that you would probably be higher in this distribution if you were getting higher rates than these other peers. And it just got me to think, like, I know how I see this as a regulator, but from a hospital's perspective, where's the right place to be on this sort of distribution, like for relative commercial reimbursement?
Again, it all depends on where Medicare and Medicaid rates are. So I think you just showed that the rates for the academic for Dartmouth on the prior slide, there's differences there as well. So the ratio of commercial rates to government payer rates factors into this as well. And as a regulator, I think what you need to look at is the commercial rate essentially justified based on the payer mix that we have here in Vermont. So I think for us, as we've done in the last several budget hearings, we've been very clear on what drives the commercial rate. I think the transparency around that is unlike anything I think that you would see in any other organization. We clearly show the cost inflation that we are projecting for the coming year. We show the expected rate increase that we'll get from Medicare and Medicaid, and the difference is the commercial rate increase that we need to cover that inflation. So these benchmark data, that's one piece of the puzzle, but we share in very clear, excruciating detail how that commercial rate is generated, and hopefully that helps the board in making its decision on whether or not it's an appropriate rate or not.
Okay, that was all that I had, Chair Foster. I can turn to board questions.
Yeah, thank you very much. Why don't we just take a quick 4-minute break, and then we'll start with the board questions. And before we do that, I just wanted to flag, just for the record, that Member Holmes wasn't able to be here today, but she will watch the tape, and I anticipate will be participating in deliberations. She might be able to join later, but if not, she will watch the tape and participate in deliberations, I think. And so we'll take a break till 9:20, and then we'll have board questions. Thank you. Member Walsh, are you back?
Yes, I am.
Okay. Okay, it's 9:20 and we can resume with board questions. Are there any board members with questions for UVM?
I'll go ahead and kick us off. That's all right with you, Chair Foster?
Please.
Okay, so thank you and hi everyone. Nice to see you this morning. I'm just to give you a bit of a roadmap. I'm going to start with some follow-up questions to the discussion so far this morning, switch to my questions from the materials, and then I have some questions that Board Member Holmes sent along that I will ask on her behalf. So in terms of the discussion so far this morning related to UVM moving into recreating some of CVMC's successful programs for growing their own, I wonder if you could speak to that a little bit more. Quite frankly, it's always been something that I've wondered about in terms of how the smaller hospitals seem to be quite successful with these programs in terms of traveler reduction. Obviously, you may have some contracted staff that are more technical, but certainly I would think that your existing staff, you would have some that would like to move into more technical roles. So could you speak to why that's been slow to get started and how long you would expect it to be really up and running?
So I'll get started and I'll pitch to Steve and maybe even Carrie to speak to that, Robin. So I think there are some pretty significant programs that the UVM Medical Center has actually implemented in the last several years to try to grow our own and create career ladders for staff. They've also funded and helped support organizations outside of the UVM Medical Center to keep them afloat so that they could continue to provide the resources we need. The respiratory tech program is an example of that, you know, without our support, you know, that pipeline of folks would have dried up for us. So I know, Steve, if you want to get started, and then maybe Carrie can talk a little bit about what's happening on the nursing side.
Robin, I would tell you just historically, prior to the pandemic, the Academic Medical Center didn't have huge challenges filling roles. There were some hot spots, but in general, we had a good pool of applicants for most positions. And the local colleges were actually helping us with many jobs. We had, for example, Champlain College was giving us respiratory or X-ray techs. And through the pandemic, we've seen that our pipeline dry up somewhat. And so we do have many programs going on. So for example, we just announced last week our respiratory therapy program, which is in partnership with Vermont colleges, where we're doing a pay to work program where people go to school for 2 years, continue on with a full-time job at the medical center or in the network. And then at the end of the program, they commit to working within the UVM Health Network for 3 years. We've been running an MRI apprentice program for some time at the medical center where we take medical assistants and train them to be MRI techs. We have a lab partnership with SUNY New York, where we've launched a 2-year medical technologist degree, which is not available in Vermont, to help train med techs, which we desperately need. For nursing, we have many programs. For inpatient nursing, we have the senior practicum, where UVM students who commit in their 4th year to working at the medical center, we help cover their 4th year tuition. We have an LNA to LPN to RN program. And we have a number of other outreach programs to high school students to bring them on. So while we probably haven't had the same challenges of the smaller hospitals for as long, we've learned from them, we've built quickly, and I do believe that the pipelines that we've built will serve us well, and I do think you'll see us do many more over the next couple of years, do everything in our power to have a stable, committed workforce that's here and can get good jobs here. And then once we get them, over a long career, can do multiple different jobs, work up the career ladder. One of the ones I wanted to mention is we have a good OR tech program, which is a real big need for us. And so we have an OR tech program to also train them here at the medical center, and the OR techs that we're training here are going out to CVMC and other hospitals in the network.
And I think if it's all right, I would add, Steve and Rick have highlighted a number of things. The only thing I would add is the strategic focus on workforce development in partnership with the colleges in Vermont. And a recent example of that is VTC in Norwich partnering to look at how we can support pipeline across a trajectory of years with our own employees in all of the Vermont facilities to bring on our own team members and grow them in place. And so that takes a concerted effort and a coordinated manner to do that and to plot out over subsequent years, not only how we grow our own employees into LPNs, registered nurses, individuals that have bachelor's degrees that want to go to an accelerated RN program. There's a number of ways to help support our own workforce. In addition to that, the colleges are really struggling with faculty related to these programs. And so we're looking at ways to partner with them to support the practical learning pieces within our own institutions to support the growth of our workforce.
Thank you. We certainly have in the past heard the challenges around the faculty component. So thank you for that. And I know you mentioned earlier that you were expecting about, I think it was 120 new grads. Overall, do you have kind of a ballpark estimate of how many staff these programs that you've implemented or in the process of implementing might touch?
I don't have an exact number, Robin, but we can follow
Sure.
up with that on all those. We'll take a note and we'll get back to you.
That's fine. Yeah, I don't need an exact number. I'm just trying to get an order of magnitude so I can have a sense of how it compares with current workforce and travelers. That's why I'm asking the question.
Okay.
Also, Kara, you had mentioned working on retention and some of the programs that you have in place for that. Would it be possible for us to get a sense of your retention rates? And obviously you may not have that, but that could be another follow-up if that would be best.
Absolutely. I think we can do that in follow-up.
Okay, great. All right. So I wanted to turn now to the PHSO. And thank you for answering some of my more detailed questions that were asked in writing around the PHSO and its connection with the blueprint and how that staffing works. I do have some additional follow-up questions. In your answer to the staff analysis questions that was submitted on August 1st, and this is on page 11, you indicated that part of what the PHSO would be working on would be delegated arrangements with commercial payers to further avoid duplication. And could you speak a little bit to what those arrangements are and which payers you may be collaborating with?
I don't know, Jessica, if you're able to answer that.
Yeah, I can answer that. So the thought there is that we would be able to do such things, not that we have discussions underway. And that part of the organizing of the work in that way is to think about how we could continue to transition to more value-based payments and work within the PHSO.
Got it. Great. And do you have any thoughts on sort of which commercial space you might move into first, should you be successful in negotiating that with a commercial payer?
I think we remain open to all transitions to continue value-based payments, but we don't have particular order of operations in terms of which payers we intend to seek first. And Kelly, unless you have any added detail there.
I think you're spot on, Jessica.
Thank you. Also, in that same part of the narrative, you indicate, and this is towards the end of page 11, certainly while OneCare makes up a significant portion of your network's attributed lives, you have other value-based contracts that require industry standard performance analytics. And could you speak a little bit about those contracts? If that is something which requires confidentiality, if you can just note that, and I could include that as a rationale for an executive session.
So I can speak broadly to it, and then if you have more specific questions, I think we can think about how to best answer those. But in terms of arrangements that we are currently in, we have a number of Medicare Advantage arrangements, and those include value-based components. And then, of course, we have our own internal population, so our own self-insured population. And that's another population for us to think about as we approach value-based care.
Great.
Kelly.
Sorry, go ahead, Rick.
Just checking see if Kelly wants to add anything there, and if it's something we can share, or if we have to wait for executive session.
Yeah, there's a variety of, there's some other smaller programs in addition to MA, and so I'd prefer to discuss that in executive session. Happy to do so.
Okay, let me just make myself a note, because by the time we get there, I don't want to have forgotten. Okay, thank you. So also related to the PHSO, I just wanted to talk a little bit and get a little bit better understanding of the graphic that you included on page 12. It looks to, so this graphic tries to show care management approach before and after the PHSO, I believe. I was a little confused about the governance and eligibility components being included as one of the functions that was centralized, because I would, for example, with the blueprint, have said that the governance for the blueprint was at the state level with the blueprint executive team. So could you just speak a little bit more qualitatively about how that transition, like what changes have resulted from that transition?
Specifically, what changes in terms of the administration of blueprint funds, or overall in terms of the way that case management is delivered?
Certainly, I think both, actually. I do have some follow-up questions on blueprint specifically.
So in terms of case management, so that's the governance referred to on this slide, and everything referred to in the now section is referred to internal to the network now. Okay. So prior to this, you had individual components that were separate. And by bringing it all together within the PHSO, we're able to standardize the work across the network and the system, and provide best practice sharing and collaboration for case management, and also think about care management systematically. So that's what's referred to in terms of governance there. And then in terms of the administration of the blueprint funds, similarly, again, talking about internal, but also thinking about our responsibility within the system to the HSAs and to the distribution of funds. And so rather than thinking about that in component parts, we're able to think about that together within the PHSO.
Okay, great. So one of the questions that I also had is in the metrics that you provided, related to care coordination expense as a percentage of total expense, that was listed in the comparators as 0.72%. Do you have any sense of what's typical with other hospitals in terms of this type of care management structure? So for example, is the PHSO structure typical, or is it different from what is typical in the industry, if you know?
So I can speak from my own experience in another healthcare system in the greater Boston area. And so I would say in terms of the cost, we are definitely within benchmark for our knowledge, or what's knowledge nationally. We can look more specifically and give a more specific answer if needed. In terms of the way case management is delivered in population health services and value-based services, more and more programs are looking like ours, or have already built structures like ours, where you're thinking about centralizing the systematic structure and then providing case management services across the organization, versus each individual organization trying to do that separately. And part of the reason why we do that is because what we want to do is align the incentives, align the contracts, and align the payments, so that we're delivering it in a consistent manner across the system, in conjunction with partnerships with payers, a variety of payers. And that I would say that's consistent for other population health management programs as well, not just case management.
Okay, thank you. In terms of the structure specifically around the blueprint, could you speak a little bit to how the staffing works and we can keep it to UVMMC for now, and I can ask about the other hospitals later. Certainly, I hear you saying there's some economies of scale to central administration. I'm wondering about individual case management FTEs that are assigned to the Burlington HSA and how those where those FTEs are located and how they interact with the community.
All care management FTEs, including those that are funded by the blueprint, are located throughout the practices. So some of that is direct embedded, some of that is virtually embedded, but they're case management teams that are provided to our practices and to our providers. And so while their employment structures may be more centralized, the actual work that they do is embedded in the practices. And that's to provide consistency for the practices and for the providers, because case management services also support providers as well in the work that they're doing. So that's they're situated across the network appropriately given the size and scope of each practice.
Got it. And then a follow-up related to specifically to the Burlington service area. In the follow-up questions that you submitted recently, I think it was Tuesday, or maybe Monday, you indicated that for the Blueprint HSA, the UVM practices, I think you said were about 37% of the HSA, and that there were 25 community practices, independent practices that were also interacted with. And could you just provide me with a little more detail about how that works? Like how, whether the funds flow are going directly to those practices in the case of the practices in Chittenden or in the Burlington HSA?
The funds flow.
The funds flow
Yeah,
and
so
the people.
For the practices that are outside of our system, where we use the appropriate distribution methodology, and those funds flow directly to those practices.
Okay, so they, for example, might be hiring their own case manager or
Correct.
embed whoever they feel like their practice needs.
Exactly.
Most. Okay.
Yeah. So the work that we're doing is for the network only, for network resources only.
Yeah. In I believe that's just in Burlington, right? So in Barry and Porter, there was some discussion in the follow-up questions about shared practices, which we can talk about when we get to those hospitals. Just 1 second. Okay. All right. So turning briefly to the ACO. So you indicated in your follow-up that that UVM intends to participate in the One Care. Is that for all 3 programs?
Yes.
Yes.
Okay, thank you. And then shifting to pharmacy, can you speak to how your trends in 340B rebates, how they've changed over time, fiscal year 21, 22, 23, and whether you expect a growth in 24?
So let me see if we've got somebody who can answer that specifically. I think we have Wes on the call. Did we swear him in? Sorry. We did swear him in. Wes, are you able to answer that?
You may be on mute.
Actually, he looks like he's not on, Robin, so we can follow up on that item. So from 20 to 22, the rebates you're looking for, the trends?
Yes, please.
Okay.
Okay. Shifting to utilization. So in your discussion of utilization in the narrative, you specifically mentioned OR sprints and also some access initiatives around radiology. to increase access, which is great to hear. I think we all know there has been some struggles with access issues in Vermont generally, but particularly at UVM. I'm wondering if you have other access initiatives that you haven't highlighted either in your narrative or this morning that you could speak to, and or your plans for access initiatives moving forward for fiscal year 24.
Thank you, Robin, for that question. Making sure he's on here. Brad, would you like to speak to that?
Yeah, sure. Good morning.
Good morning.
So I would highlight, and I believe this came back in answers, maybe in some of the other questions, our electronic consult initiative. So this is the ability for a provider to ask a question to a specialist. So those numbers continue to expand. That's a key initiative in fiscal year 24 that we're looking to assertively expand. And then also some key investments in provider recruitment. And really, what this comes down to is really some staff and some better systems to make it more efficient, specifically around sourcing. So being much more proactive about sourcing these recruitments rather than being passive.
Okay. And in terms of the e-consult, I know in your narrative you did speak a little bit to how that impacts revenue for both the referring or the consulting providers and the specialist. Could you just go into that in a little more detail? Because I want to make sure I really understand how that translates into dollars.
I'll take that one as well, Brad.
I'm not sure I'm the ultimate expert on the revenue side of that. I don't know, Rick, if there's someone else on the team on the call.
So you're looking for the impact on the revenue from both the specialist and the primary care perspective, Robin?
Yeah, because certainly you can see how that would increase access to specialty care. I just don't understand how that then translates into utilization and NPR.
Yeah, so the way to think about it is, one, it definitely, on the specialist side, it creates more appointment slots if there are issues that are being taken care of in the moment with the primary care provider. So it creates access availability there. From the primary care perspective, I'm not sure there's really a revenue impact necessarily, but certainly they're getting through their visit in a complete way. They're not having to wait for, the consult or the guidance to come back from the specialist. So from a revenue perspective, it would really be purely on the specialist side that it increases the access for them to see more patients.
So Rick, if I could add just a couple of quick points. So Robin, we don't bill for the e-consults, but we have some good data that shows that 30% of e-consults don't require a specialty visit afterwards. And so that opens up 30% of visits for patients who do need to see the specialist. That's the big opportunity here. So the specialists like it because the people that are coming to see them really need to see them and can see them more quickly. That's the real benefit here. And we really think that over this year, it's going to really improve access for many of our key specialists that are hard to get into because there'll be 30% new spaces, the way I think about it.
Okay, got it. Thank you.
I think that by and large, when you look at that, it's really about how do we get greater access for our patients to get the specialty care that they need. And then hopefully the secondary benefit is what Steve is talking about. And depending on the specialty, it can translate to more direct revenue.
Ready. Okay, thank you. In your discussion, so the other question I had is around the building of the shared services organization. How do the New York hospitals contribute to those expenses? And what's the general New York, Vermont split there?
So the way that we do our shared service costs is we combine all the shared services into one pot, if you will. So right now we don't have a network employer. So the employers that we have are the UVM Medical Center, CVMC, Porter, and the New York hospitals. But we aggregate all the costs for our shared services. So we aggregate all the IT costs, HR, marketing, revenue cycle, all gets aggregated, and we come up with a total cost for all of shared services. Once we have that aggregated cost for everyone, we allocate it out to all the hospitals based on their proportion of net patient revenue. So the New York hospitals get their allocation based on how much net patient revenue they make up of the network total. There's a little bit more detail behind that in that we then have to essentially credit anybody that contributed at expenses to the pot of money, but very basic. That's how we do it. We combine it and then we allocate it based on net patient revenue.
Okay, and is that actual NPR like from the prior year? Is that projected NPR for the current year?
We use the budgeted NPR for the coming year.
Okay, thanks. Okay. On page 28 of the narrative, there's a discussion related to known increases for Medicare and Medicaid that are included in the budgets. The Medicare projected increase in inpatient rate projects an increase in inpatient and a decrease in outpatient. Can you just speak to that in a little more detail?
So the inpatient rate increase, actually I might call on one of our team members here just to make sure that I've got this correct. Mark, are you able to answer that question on what specifically is driving the inpatient and outpatient rate?
I only have the blended rates for Rick for Medicare, so we'll have to get the split of the mix back, split out by in, out, and pro that we used.
Thank you. It's fine to follow up if that's the easiest course. So let me just tell you a couple other questions related to this page. I'm also curious about the relative weighting that gets you to the average rate increases on page 17 of the narrative, and how an increase in Medicaid from New York is factored in. So I think those are all of the questions on those 2 pages and you can follow up.
So which chart specifically on page 17, Rob?
Hold on. Let me get to page 17. So it's the average rate increases. So I think that would be in the bottom half of the page.
So you're looking what the assumption is behind those rate increases, and then how New York Medicaid factors into that?
Yes.
Okay. So for Medicaid, that one we can speak to specifically right now. So those increases that you see there, the 0.7, the 1.9, and the 2.2. So those are the primary care rate increases that the legislature approved earlier this year. The reason why those percentages are different has to do with the proportion of the services in those organizations that are made up by primary care. So for Porter, there's not a lot of additional services beyond primary care. They have some surgery, some radiology, but since their services are made up by such a large amount for for primary care, that percentage increase is higher for them versus when you look at the UVM Medical Center, there's many more services, so the impact of that primary care rate increase is much smaller.
Got it. So for example, we believe that there's a 7.5 increase in Medicaid from New York, so that's not factored into your Medicaid percentages. Presumably that could impact UVM given the number of transfer patients you have from New York. Is that a fair assessment or assumption?
Yeah, we'll have to take a look at that. The vast majority of that increase obviously benefits our New York hospitals, and there is a small portion of that, yes, that would flow across to Vermont.
Okay, yeah. So if you could follow up on that would be great. And so this next question is a question from Dr. Holmes. So I will do my best to ask it. What role does increasing productivity in clinics have in increasing access? So you've shared with the board your visits and clinical FTEs per month. In her analysis, she didn't see measurable progress increasing throughput for the past year. The number of visits per clinician seemed low. So could you speak to how these sort of your plans with these numbers, and can you explain some of the lower numbers? For example, average for this year, pulmonary 3 patients seen per provider per day, ortho spine 5 seen per provider per day, peds cardio 4, peds endo 3, infectious disease 4 per provider per day, etc.
So I'll turn to Brad, and I think Jen Gagnon can also help to answer that question for you, Robin.
Yeah, absolutely. So in general, the more, quote, productive our providers are, the more access there are. And that's not to imply based on the demand that we are keeping up with the access demand. I am, Robin, I'm sorry, you may have to reread it. I am confused by the per day piece, because I thought we submitted visits per month.
Well, that would actually be worse, to be frank, because the numbers that Jess pulled out were average over the course of the year, 3 pulmonary patients seen per provider. She said per day, but if that's per month, that would obviously be fewer. So perhaps what would make sense is to go back to that exhibit that you submitted. We can perhaps Sarah can help me write this up as a follow-up question, and you can provide.
Robin, can I jump in for a second?
Please, Dave.
Well, I was looking at some of this data as well. So I think what I did was took like the month of July 2023 in that, which and then divided by 20 clinical days. And I estimated about 240 clinical days per year. So if it's about 20 work days per month times 12 months was 40 work days per year. So that's where you get to these per days, because I think that's the kind of almost a more intuitive way to look at these data. So, we have, when you look at that for say, telecardiology, 1,200 patients per year, it's 5 patients per day. Or in July, 86 patients, which is 4.3 patients per day per clinical FTE is the way that data was sent.
Got it. Thank you, Dr. Merman. That makes sense. So I think the difference there is we provided data on what we refer to as our full clinical FTE. And if you do the math that way, there's an assumption that this is really the ambulatory clinical FTE. So most of these providers have clinical effort on the inpatient floors, clinical effort with call, so that you couldn't really do the math, I don't think, in that way, because the clinical effort's much more than just being in the ambulatory clinic.
Just as a follow-up then for that, to talk about that now, then would you be able to adjust this for ambulatory clinical FTE? Because say like endocrinology, 8 patients per clinical FTE per day is what I see in 2022. You know, my understanding is that the endocrinology group does not have, you know, a significant burden outside of the clinic, but maybe I'm mistaken on that. But it would be really helpful to see these lists per clinical FTE and per month, per day, per year. We can divide it out, make it whatever looks easiest to read, but then also, and then benchmarks for that. If you have like Vizient benchmarks for what would be an expected per clinical FTE per day productivity.
Yeah, no, I totally appreciate where the question is going. It makes a lot of sense. You know, my direct answer is I don't know how much work that would take. We can take that in follow-up. And, you know, for example, you know, maybe an obvious example, like with spine, you know, when we have surgeons in the OR, you know, that's part of their clinical FTE. So I'm happy to, you know, follow up with who's appropriate and look at an example or two.
Brad, what I would add is that, and I'm not close to the medical group salary system as much now as I have been at other times, but every physician here is benchmarked to get across a productivity target. So I'm confident through Sullivan Cotter or something, we can share back good data that shows the productivity of our providers. And the providers here are all academic physicians. So they have a teaching mission, many of them have a research mission, and many of them have clinical, both in the clinic and in the hospital, as well as call. But I'm confident we have that data to share back. The benchmark.
And I do think David and Robin, I think those are really good questions. And Brad and Jason, I think we need to figure out a good way to deliver this so that we can compare it. So I think it's a good question. We probably haven't done the work yet. We got to come back and do it. And so it's probably not 240 days a year. It's probably 225 days a year because there's vacations, right? So we should probably have a standardized way to be able to show you what an FTE is and what a clinical FTE is in the ambulatory space. So I think we have to take that on as work, whether it's for this budget or for the next budget. It seems important for us internally and for you. So I hear that.
Thanks for the opportunity for the interjection, Robin.
Thank you for bailing me out, Dave. So on page 35 of the narrative, you cite one of your major strategic projects next year as related to Fanny Allen. Could you speak a little bit more to what that plan is, what you think the expected cost of it is, and if you were to be granted the CON for the ambulatory surgical center, would you still purchase Fanny Allen, and does that make sense?
Yeah, so our lease is running out on Fanny Allen, so we have to do something if we want to keep that that facility, and we feel like it's a very strategic location for us. There's just not a lot of land left in Chittenden County. There's not a lot of property to develop, and obviously as you've seen in we didn't hit on it too much in this budget narrative, but in prior budget narratives, we shared the population projections and the aging of our population here in this market area that is going to demand a lot more facilities and a lot more resources to take care of the patients for years to come. So we have to nail down opportunities for land where we can and facilities where we can, and we view Fanny Allen as a key to that. That we would certainly need that campus, even if the outpatient surgery center CON is approved. Steve, anything you want to add?
What I would add, Robin, is that we desperately need the outpatient surgery center and the Fanny Allen campus. The Fanny Allen campus serves acute rehab. When we had to close acute rehab, we did not find a good suitable location in Chittenden County to move that. So rehab is open there now. We do a lot of imaging there, physical therapy there. We have an urgent care there that we think is ideally located for Chittenden County. And when we get the outpatient surgery center CON approved and we're able to move outpatient surgery there, we'll repurpose those ORs to improve access. We're not exactly sure what we'll put there, but something. There's also a medical office building there that's important for our patients. And there's other space there that could be developed. Last I'll mention is parking. We have a desperately short number of parking spaces for our staff, and that parking lot is one of our key locations. So the Fannie is part of our future even after we get the OSC approved.
Thanks. So turning now to your balance sheet, on your balance sheet, there's a jump in current assets from a budgeted 87 million to this year to 198 million. Can you provide more detail?
So that, I believe, is our planned borrowing, but Mark, can you validate that?
I'm here. I was just clicking through some files. I would have to see the exact line, but that would be the material item. And if that's related to anything, it is probably what related to the potential borrowing or related to the new OSC in that line.
Thanks. On the P&L, it looks like in March, it was estimated that UVMMC would realize 60 million in revenue from the sale of investments. You've budgeted 17 million. Do you have updated estimates for gains from sale of investments for fiscal year 23?
We do have more months of actual data that we can follow up on that. Robin, unless you have the numbers right there in front of you, Mark.
No, Rick, that's a part of our balance sheet. You know, Robin, that we work together with our portfolio managers, and they make moves along the year that based upon current trends. So we'll just have to get back to you to see if the trend is any different than what we projected.
Okay, thank you. And if you could also get back to us with an updated projection on net operating income, which in the budget submission was budgeted at 39 million, that would be great. And then just one last question, which is, where do you book your donations? We didn't notice community foundation revenue or general contributions revenue on the P&L.
So any donations that are, so first of all, they have to be used. So if the money has actually been used for supporting staff, you know, purchasing some supplies, where you see that come into the P&L is the expenses incurred, and then in the other revenue section, there's a net assets released income line. So whenever we use those donated funds, endowment funds, specific purpose funds, that's when we recognize the revenue on the P&L when we've recognized the expense.
Thank you very much. I think that's it for me, other than for executive session related to those contracts. So I'll turn it back to you, Chair Foster.
Actually, Chair Foster, if you don't mind, we do have Wes on the line now. Wes McMillan, he was having some technical difficulties, so he can at least answer one of the questions you had about the 340B rebates trending from 20 to 22. So Wes, are you there?
I'm here. Can you hear me?
Hear you.
Can I ask Mr. Vincent, was he sworn in? Oh, I'm sorry.
Same question.
Yes, he was on the list that we sent to you. It's Wesley McMillan, VP of Clinical Pharmacy.
Yes, but was he here for that portion? Do you know?
Oh, I don't know.
I was.
Thank you.
Yeah, you're welcome. Thank you, Robin. The 340B program within UVMMC has definitely grown organically over the last couple of fiscal years, and going back further than that, and largely driven by increasing patient volumes, both in our outpatient setting and within our retail footprint. So the 340B program is dedicated to outpatient medication procurement for patients who qualify for the program. So over the last couple of fiscal years, it's grown very nicely, based on our patient care volumes increasing. What's going to happen within fiscal year 24 is that our pharmaceutical manufacturer colleagues, if you will, have restricted access to 340B discounts across our contract pharmacy arrangements. And that impacts UVM Medical Center, CVMC, and Porter Medical Center on the Vermont side of the shop, as well as our upstate New York partnerships as well. The value of the program within the contract pharmacy arrangements is in the tens of millions, and expected that number will be significantly impacted with these manufacturer actions. We're doing our best as a network to mitigate the financial impact of that, so that the true financial impact and added expense is really unknown. We're going to continue working towards mitigating those financial impacts, but something that we'll have to work through in this coming fiscal year.
Thank you. And you can certainly provide this as follow-up if that makes sense, but it would be helpful to actually see the dollars and the trends over time, which may be buried in the materials and I missed it, but it would be helpful to see it all in one place. So thank you. If you could follow up with that, that would be great.
Okay, great.
That's it for me.
All right, thank you. I have a couple questions relating to the August 17th letter that was sent regarding the benchmarking tools that we used. A case mix index is referenced in that letter, and that measures patient acuity. Is that right?
Correct. Yep.
And what does it look at to measure that?
So it looks at sorry, just trying to get to my notes here, Chair Foster.
Is it diagnoses, instruments, severity, those kinds of things?
Correct. Yep.
Chair Foster, it's what's documented in the chart around the patient's acuity. So when the patient presents and the physician writes the note, writes what their past medical history is, what their current symptoms are, what testing has been done, that adds up to a case mix index. So if the chart is incomplete in any way, or you don't capture some key piece of information, that will make the case mix index look artificially low.
And that then impacts your DRG billing?
It does.
Okay. And what impact does that have on the different payers? Does it only impact Medicare, or is it commercial insurers, Medicaid?
It's primarily Medicare, but the acuity of the patients do, for some small portions of the other payers, it does impact payment there as well.
Right. And then the data point Director Lindberg had, the adjusted cost per discharge, is the cost for a single discharge at your hospital, but it's then adjusted for how complex those patients are based on that CMI?
Correct.
And on the tool that we have, I think the data that Director Lindberg had was UVM's cost per discharge was 14,000 and maybe around like the 75th percentile or so. But your view is that data is misleading or inaccurate?
Yes, due to the case mix index. So as I shared earlier, the case mix index. So when you look at that top right-hand chart that Director Lindberg has up right now, the UVM Medical Center data point is the 2.05%. So we know that we're not appropriately documenting and coding the acuity of our patients. That's where we spoke about the iodine system that we just finished the implementation on. So with an appropriate and accurate accounting for the acuity of our patients, that will change any type of CMI adjusted cost calculation. So the chart down on the bottom right-hand corner there, all expenses remained where they were, no changes. A change in CMI would drive down that average cost per Medicare discharge.
And Chair Foster, what iodine actually does is it reminds providers of things they might have missed. So it says, we're looking at the chart and we found you didn't actually document maybe the person's potassium or something like that. And it helps the provider to appropriately document all the important elements.
Provider have these alerts while they're billing, and then the system prompts them to make adjustments?
It's not while they're billing. It goes back and looks at the notes in real time and captures places for the provider to add important information to the chart.
And when does the provider?
It's even. I'll give you a really simple example. A provider may have asked for a potassium level, and that potassium level could have come back high. And they have made even comments to say that this patient has a high potassium level, but they never wrote the words hyperkalemia, which means high potassium. You have to have those words in the chart to be able to bill for hyperkalemia. So what iodine would do is say, gosh, I see that there's some data that says this patient has high potassium. You've mentioned the words high potassium, but you've never documented hyperkalemia. Does this patient fit the need for hyperkalemia?
So this comes back to the doctor after the VIT, not when they're billing. It comes back to the doctor later.
No.
But
So what's great about iodine is it does it in real time.
Yeah.
So there's a couple of things. One is you can capture comorbidities even before the patient gets there. So you can know that these patients have a history of A, B, C, D, E. So the patient's going to come in to see Steve. It's already on his chart that this patient has a history of these things. So you're cued into that. Number two is while you're there, as the hospitalist, you can see the things that are happening and you can get reminders. And then there is a part that looks back on it in 24 to 48 hours, depending on how efficient you are. And then there's a part that looks way back and then says, Steve, you have a tendency not to code congestive heart failure. When these criteria are met, will you actually document that? So there's an educational process to that as well.
Yeah, I've seen this. Some EMR systems themselves actually have this technology. I don't know if Epic does, but your letter that this was sent to the board says that UVM's known, quote, known for some time through external assessments and comparisons to benchmarks that we're not accurately capturing the acuity of our patients. Can you advise for how long UVM's known that?
I would say that this goes back to pre-pandemic, so 2019, 18, 19. We've known that we've had an opportunity to increase the accuracy of our coding and documentation, and this doesn't only impact CMI, but it also impacts quality metrics. So when we look at the Vizient database and looking at how we compare mortality rates, for example, readmission rates, that acuity of the patient factors into those numbers as well. So that's really when we started to use traditional methods to try to improve the accuracy of our coding and documentation that really hasn't resulted in the impacts that we've been looking for.
The letter.
I just want to add to that, please. I would say that while all hospitals are continuously working to improve their documentation, so it's not, not a foreign thing for it to be at the medical center, I will say that during a latter part of fiscal year 22 and fiscal year 23. It has been a focused effort, while it has been a manual process, a focused effort to look at service lines and what is the typical case mix index. And we have been focusing and educating on that. And we have seen some financial improvements in that documentation. And iodine itself is kind of the next level of improvement to automate and make it a simpler system for our providers to provide that additional information via query.
The letter references some external assessments and comparisons to benchmarks. Can you flesh that out, what those were and when they were done and how many of them were done?
We'll have to get the detail behind that. We know we had 3M did an assessment, but we can get you some more detail on exactly how many of those were done.
Do you have a sense of the timing of when those were performed?
Not off the top of my head. Well, we can get back to you.
Just directionally, was that something sort of undertaken like this summer or years past or some sort of mix?
It wasn't this summer, so more goes back more than the summer when those assessments were done.
Okay. And do those assessments, you had a projection in the letter, did those assessments play into the projection that you submitted to the board?
That's our estimate on where we think our CMI will land when we are accurately documenting and coding the acuity of our patients.
And is that assessment based in part on what the assessments or the benchmarking that your letter references showed?
Correct.
Would you provide the board the benchmarks and assessments?
We can, yes.
Can you, on the projection, so I get the point that, like, you know, this data you think makes UVM look less favorable than it should. And if the board used this 2.3 range, it would change that. Can you walk me through how that projection was performed?
In terms of the calculation?
Yeah.
So if Sarah wants to pull that, if you don't mind, Sarah, pulling that back up on the screen, that chart that you had up a little earlier.
Which chart? I'm sorry, I got chart.
Sorry, the calculation that shows what happens when the CMI changes.
There it is.
So this is the calculation that that we included in the letter that shows what happens when the CMI increases for this calculation.
Right. Sorry, I was focused on the calculation that was performed to conclude the revised CMI should be 2.3.
Yes, we can provide some additional detail behind that that calculation as well.
When was that projection performed?
When we received the first time we looked at the budget tool, which was on August 1st, we started going through all the different components of the budget tool, and we started looking at the areas where either we were within benchmark or we were outside of benchmark, and this was one that was flagged. So we dug deeper into the data, and that's when we started to look at this specific metric.
Can you orally walk me through how the projection was calculated?
We can provide that detail for you later this week.
Okay. Yeah, if there's work papers or math behind that, that'd be great if you can send that over to us. If you're not prepared today to speak to it, that would be helpful. When do you anticipate UVM's CMI increasing? Like, is it going to be, you know, you said that you've had 2 weeks of this new program. will we see it reflected in this year's performance, or will it be sort of a 3-4 year thing to get up to that 2.3 level?
So we did increase the CMI number for our 23 or 24 budget. It won't all happen this year. It likely will be a year or two before we get the full impact of this. We'll be analyzing the new workflows that have been put in place in the system itself to look for opportunities. Sunday, I don't know, you implemented a similar system. I don't know if you have a sense on how long it took before you started to see the real impacts of the system.
Yeah, it's trickier than you might imagine. It takes a real cultural change, because what has to happen is that there needs to be a relationship between the nurses who are using the software tool and seeing the opportunities, that relationship between the nurses and the doctors, so that they're talking to the doctors, calling the doctors without harassing them, because they're already overtaxed. And the last thing they want to hear is like they're not documenting properly. And so the doctors have to kind of go through a training process to be able to appreciate what's coming in at them. So that's the work that has to happen behind the scenes. And we have to be delicate and careful about it, because docs and nurse practitioners are feeling like they're being pushed so hard already. And so that's the walk that we're doing. First, there's a lot of education. You take that on slowly, start forming relationships, and then you start going in and saying, oh, you're going to get these automated messages. If you have any questions, come back and talk to me about it, but here's what we're going to target. And you usually take it on piece by piece and build. And then people hopefully start to learn that, so they don't need to get those reminders that when you check a high potassium, that you can write hyperkalemia, et cetera, et cetera. That makes sense. So that's why it takes some time to build up and change the culture to be able to get us there.
Have you performed any sort of risk assessment of the likelihood that your projections will bear out?
We have not, no.
And, you know, this is one of the factors that I am considering for all hospitals, and sort of my thinking of the budget requests is how expensive are they? And it could impact how I think about UVM's budget request. And that gives me a concern that there's this number in this letter that's a projection that may bear out in 2 or 3 years, but it might not. And so I struggle with, should I rely on it to decide that Vermonters should pay more money in the commercial rate? And what happens if the projections don't bear out? What's your feeling on that?
I think you have to take the. Go ahead, Sonny.
So, I mean, I think that if we do better on the way that we bill Medicare and that we get reimbursed, that would be a positive in the long run and would decrease how much we would need to get from our commercial payers. So I'm a little confused. Ask me that question again, Owen. Are you saying if we don't reach this, we'll need even a higher commercial increase?
No, close. What I was saying is I might rely on this number to determine that your rate request is appropriate to some degree, because you're not as expensive as you look according to this number. And so it would incline me to maybe give you more money on your request. But if your request doesn't pull through, then I've given a rate increase that's higher than I should have. And that means Vermonters have to pay more. And so I'm concerned about relying on a projection to do that.
Well, I would like to add that
Rick or Judy,
I would like to add that, of course, projections are always estimates, and just like when you're doing budgets, they're estimates on what you know at the current time. And what I can say that I do know is that the medical center has exceeded its budgeted case mix index for fiscal year 23 because we have focused on that area as an area of improvement. Where we think that we need to really dig in is how we're training our new providers that come on every July. And as we focus in those areas and we make those improvements, it won't necessarily be in year one, but we do see the pathway to get to the 2.3. And your question about are you over providing in terms of a rate increase, I would say no. There is a pathway to get there that will improve in terms of our cost. However, factoring what we have put into the budget, I think is an appropriate rate request. And I do feel confident that we are committed to educating our providers to ensure that the medical records completely capture all of the great work that is being done to care for our patients. So we've already started that process in a manual way. We're adding on a electronic version of that. And I do think that adoption will come, and we are monitoring those even as we speak now.
One last comment, Chair Foster. For as long as I've been in leadership, we've been wanting to add a tool to help providers remind them to do better. And one time after another, there's been an issue, things like a pandemic, things like Epic upgrades have, and things like having financial issues have made it difficult to add the tool. We have finally made the commitment to add the tool. We've been educating our providers. We've done rollouts. The teams have done a very good job. They've made it easy for the providers to provide additional important information. And so I think our charts will be accurate, more accurate based on this. And what you're saying is, are your charts accurate? This will improve the accuracy of our charts, the accuracy of what's in there. So I am confident the number will increase. Exactly will we get to 2.3? It's always a goal, right? We'll keep stretching, but we know other academic medical centers have done similar programs and gotten the results that we're projecting.
Yeah, you should hold us accountable to it.
Yeah, I mean, I think that that's a fair point. And, there's personal accountability for who's ever responsible for these projections. And I would hope that, it's really dangerous for us to give big rate increases with the affordability challenges we have. And if we do it based on a representation and a calculation that the medical center has made or the network, there should be accountability for somebody if it's wrong, somebody that did it. Like somebody should be responsible for these things, because asking us to give large rate increases is really hard on Vermonters. So I'll just put a plug in for personal accountability, because it's really hard for us to give that money, have it turn out to be wrong, and tell Vermonters, sorry, we made a mistake. So I just think that's critical.
Yeah. So Owen, I guess here I feel like we're stretching ourselves to get to this number, which we haven't done in past years. And this is allowing us to lower our ask for our commercial rates, right? So I think it's great that you're holding us accountable. We want to reach this number. If we exceed this number, we'd be happy to come back and show you that, and show you the impact of what that would have on future commercial rate increases as well. So I think this is what you want us to be doing, because it would have been easy for us to just sit back and say, yeah, we'll continue to get the same CMIs that we've been getting. And what we're doing is doing just the opposite. We're challenging ourselves to be more accurate, to be better about the way we're documenting in order to collect the dollars that we believe we should get from Medicare. And that will decrease our ask to our commercial insurers.
And that's because the cost shift thing people talk about, the Medicare pays too little. So if you're actually billing Medicare properly, they'll be paying more. Therefore, you don't have to put so much on commercial. Is that what you mean?
Yeah, that's exactly it. You've seen that our commercial rates are calculated based on what the Medicaid and Medicare rates are.
Right.
So if we can get more out of that, in Vermont, the Medicaid, Medicare rates are fixed ultimately, and then the commercial rates make up the difference of what our costs are.
Right. How much money would this be if you're budgeted for your CMI at 1.88? If you went up to 2.3, how much money are we talking? It looks like you're. Why don't I'll leave it there.
Yeah, it's in the neighborhood of around $20 million if we were able to get to that number.
Chair Foster, I'd just like to add one point to this discussion. Jason Sanders. Just our earlier discussion, we talked how CMI is also a mix issue of the patients we care for, and particularly the patients we admit. So part of the projection will always have the day-to-day decision of that community care we provide, as well as the tertiary quaternary care. And the more community care we provide is a dilutional factor in the overall CMI.
Thank you. Okay. So if you've been underbilling Medicare because of this issue, and it's predominantly a Medicare issue, and you shift Medicare shortfalls to commercial, does that mean that Vermonters have been paying for that shortfall in billing?
I wouldn't say that, because obviously you've seen our financial results the last several years, and the way that that we focused on the commercial rate increase is based on cost inflation. We certainly, if we do better in this area, there's opportunity to continue to have that impact the commercial rate. This is an area that we'll continue to work on, and hopefully we'll in the future, certainly this year with our efforts with the iodine implementation, will impact the finances and commercial rates in the future.
But if it's going to impact it in the future, didn't it impact it in the past?
I think there are many different components in the past that that impacted our finances and our commercial rates that that you can't attribute solely to the CMI increase that we haven't been able to capture.
And those factors are different in the prospectively?
No, they're not different going forward. We still need to evaluate all the different trends that we see, whether it's a cost trend or a volume trend, and we put together our budgets based on what we project those to be, and CMI will be one of those variables that we include, like we have in the past.
Yeah, but and I'll answer your question. If there's something that we find that was being done inefficiently and we can do better about it, you're right. If we had done it more efficiently in the past years, it would have shown a benefit to all Vermonters. So everything that we're doing to try to get more efficient, our PHSO, our services like HR, where we try to use the economies of scale. If we could have done it better last year, it would have saved Vermonters money. If we could have done it better 10 years ago, it would have saved Vermonters money. You're absolutely right. So we should be continually trying to do this, which is what we're trying to do. So this is one example.
That is what we all want. It's what you want. It's what we want. It's what Vermonters deserve. I agree with that. And this goes to the accountability piece. So on some level, there's been some portion of $20 million a year because of the documentation issue that's been pushed to Vermont commercial insurers by your budgeting structure. And I feel like that's difficult as a regulator to tell Vermonters. I speak with a lot of them they're upset about the rates. And so I have to tell them UVM had an issue. Look, we all have issues. This care board has issues. Yeah. I've got issues. We all have challenges.
But I would push it back the other way. I think a really good regulator
Chair Foster, I'll just add until Dr. Eben makes it back. We've been working on case mix index.
Sorry, I lost you as my computer died.
but can you hear me now?
That's a quick recovery.
Yeah, well, I've got it on the phone, but I was going to say that really good regulators would have caught that our CMI is low. And it would have been a really good external sort of reference to say, hey, are you sure about your CMI compared to the other academic institutions? It seems to be low. I don't think our job here is to try to put blame on different people. I think that is like, how do we work together to get to that right point?
If I can interrupt for a second, it sounds like you just did.
No, I mean, no more so than you did. I would just say that it's us working together to be able to identify these kinds of issues.
Yeah.
Chair Foster.
I think that's sort of a common refrain, like I've heard it in many different walks, that, you know, it's the regulator's job to find the issue. And I think there's some truth to that. We would love to find that, but I think it's very hard to do. Maybe we do have some culpability for not finding this issue, maybe. But it's your billing, it's your billing. So I kind of feel like we can debate this, but.
Chair Foster, I've been in leadership at the medical center in one role or another since 2006. And every year I've been in leadership, we've worked on improving case mix index. It's a constant project for clinicians to do a better job of charting. The physicians mostly want to do it for quality, not for billing. And so physicians sometimes don't realize that writing hyperkalemia matters because they just want to have a chart that shows what's going on. But every single year, we've done work to try and improve our case mix index, mostly to drive improved quality. And recently, there's been tools that you can purchase that help make it easier for clinicians. We haven't been able to buy those for certain years or implement them because of other huge challenges. But case mix index is critically important because we want to capture the quality and safety of the care we deliver. We want the charts to be accurate for that. And billing is a side part of that. But I can guarantee you, we've been very focused on doing our best. And we've done a major project at the medical center this year. And we've put case mix index improvement of $9 million into our 24 budget, which we're accountable to. Thank you.
I appreciate that. And I get it. No one's perfect. We're not. The medical center's not. We get it.
David, Dr. Claus might want to share a comment or two, if you don't mind, Chair Owen.
I'm prepared to move on. I've got a fair amount of questions. So if you want Dr. Claus to send something later, that's fine. But I think we should move on.
Chair Foster, could I have a quick moment to call back in with my backup recorder? Just take a brief second.
Yeah, why don't we just take a 2-minute break? We'll come back at
Thank
10:40 if that's sufficient.
Thank you.
Thanks.
Thank you all for your consideration.
Okay, I think we can resume. I want to shift to the discussion in that letter relating to pharmaceutical expenses. The retail pharmacy expense is budgeted at $170 million, or a 49% growth over 22 actuals. It strikes me as large, and I was curious what impact that had on your budget request.
So the pharmaceutical expense, and I'm just going to, Sarah, again, if you don't mind pulling up that chart that we included in the letter, just so we're speaking to the actual numbers there, that would be great. So our pharmaceutical expense is made up of two components. So one is the expense related to the pharmaceuticals that we provide during patient encounters. So if a patient on an inpatient floor receives a pharmaceutical, or an outpatient clinic, or one of our physician offices, there's one component of our pharmacy expense that is tied to that activity. And then another component of our pharmacy expense is retail pharmacy expense, which is covered by revenue that is not patient related revenue. It's retail related revenue. So in terms of our budget requests, the piece that is tied specifically to our rate needs, so from the rate needs from Medicare, Medicaid, and commercial, is only the component that is tied to physician to patient encounter. So if a patient that is on an inpatient floor or an outpatient clinic, those pharmaceutical expenses are tied to the rate need.
Okay, and the retail pharmacy, that expense, does that have any impact on your NPR request or your commercial rate request?
It does not. So the retail pharmacy revenue actually flows in a different revenue line. So it's not part of NPR and does not impact the required rate increase.
Okay. So is there any relevance to that number, the $170 million expense increase for this budget?
So for retail pharmacy, no, there's no relevance to that in terms of the rate increase needed. There's no relevance.
Okay. And then the part of pharmaceutical expense that is part of NPR, I think it's in the budget at $120 million. Is that $120 million of expense that is net of revenue that may be associated with it?
No, that's the true expense related to the pharmaceuticals. The revenue that we estimate, and again, for the pharmaceutical expense revenue or the pharmaceutical revenue that we generate through patient encounters, we can't get to an exact number because the reimbursement for many of those services is either on a DRG or it's paid in some other episode type of reimbursement where you get one payment for the pharmaceutical, the stay, and anything else tied to that encounter. We can't come up with an exact estimate, but based on using our aggregate collection rates, we estimate that revenue to be about $248 million.
Sorry, just to make sure I'm clear, it's $120 million expense, and the revenue related to specifically the pharmaceutical component of that expense is $248, or for all of the services associated with those pharmaceutical expenses?
No, just the pharmaceutical component.
So the $120 million expense, is that having any impact on your commercial rate request?
just the cost inflation on that expense. So the way that we calculate the required rate increases, we aggregate the cost inflation on all our expenses, salaries, pharmaceuticals, supplies. So only the cost inflation component of the expense is what factors into the needed rate request.
And how much money is that on this 120 million?
That we'll have to get back to you on exactly what that number is, unless we might have a chart here that has broken that out.
Rick, it's 4.6 million.
Thank you, Mark.
Thank you. So I might understand this, but if the 120 million is all covered by the associated revenue, why are you adding expense to the budget relating to this?
So we're adding cost inflation to the budget for that expense base. In terms of the revenue covering the cost of the expense, this is the dynamics that we have within a healthcare organization. You have some services that we provide that generate margins, some that lose money. Pharmaceutical revenue obviously is one that makes money, that goes to subsidize other parts of the healthcare system that lose money. So what we look at for rate increase is what do we need to cover cost inflation. That's one dynamic that we don't have the ability to absorb through other means, and that's how we determine we look at cost inflation for the entire amount of our expense base that needs to be covered by the appropriate amount of rate inflation to offset that increase.
And how much did the revenue associated with this expense go up as compared to last year? So you said it's 120 million. So it's 108 to 120, but only 4.6 of that is cost inflation. Did the revenue side of this go up as well, or was that flat?
I would assume that the revenue piece went up as well, but we can get back to you on that.
Okay. And so even though that expense line might actually be making money, and theoretically it could be making even more money than last year or 22 actuals, it's included as an expense that should drive higher rate because some other place in your hospital had losses that weren't covered?
Again, no. The only thing that factors into our rate need, and to be clear, it's not just commercial. What we need for rate increases for Medicare, Medicaid, and commercial is only the cost inflation component of our expense base.
Right. Shifting to utilization, you speak a bit about the aging population and the people moving into Chittenden County. Did you normalize the increased population shift to Chittenden County based on the demographics of those folks?
We did. Again, just to use as an example of the impact that utilization has. So in the budget narrative that we submitted, we did include a chart in there that shows the differences in age bands and how they utilize healthcare services. So we looked at those that are under 45, those that are between 45 and 64. Actually, if you scroll down a little bit, to show the differences in how healthcare utilization changes as you age. So we have, again, just to show the impact of the growing population and the aging population, we showed both numbers. We showed the impact of just the population changing, which is the first chart you see there, and then normalizing that change for the differences in the age bands.
Okay. Have you had utilization estimates in your prior budgets? I know you have. And my question is whether or not those projections have borne out. How accurate have you been in the past in connection with estimating utilization for your budgets?
So for the last few years, it's been a little bit more difficult to do. Certainly this year's budget was much easier to do as things are stabilizing back to more normal predictability. 21 coming out of the pandemic, 21, 22, that utilization was obviously more difficult to predict, but because of the large decrease in volume in 20. Going back to pre-pandemic levels, when the historical trends were a little bit more stable, I would say we were very accurate in coming up with those estimates. My feeling is that our FY24 budget, we're back to that place based on FY23. In FY22, we now have a lot better sense on where volumes are headed for the coming year.
And I hear a lot about the housing challenges people are having. Does your estimates on population growth, do those things consider whether or not there's even enough housing for that kind of population increase?
No, we have not factored in an adjustment factor for what impact housing may have on that continued population growth.
I want to shift to admin expenses. I think you discussed this a little bit with Member Lunge. But, the letter says that I took away that our calculation we had is misleading in your view because it includes all of the health network shared service salaries that run through UVM. Does that mean you spoke earlier about there's an apportionment for different hospitals based on their NPR. So if the medical center is 65% of your NPR as a network, that means 65% of the admin expenses in the shared services is attributed to the medical center. When you say that that the shared services run through UVM, does that mean all of them or just UVM Medical Center's apportionment?
Yeah, so the difference there's two different calculations that are happening here and two different calculations that we're talking about. So in terms of how we allocate shared services across the network, that we allocate proportionally based on net patient revenue. In the budget tool, the data source that they're looking at there is not our financial statements. So it doesn't factor in the allocation that we've made for shared services based on net patient revenue. What it's looking at is purely cost report data before any of those adjustments have been made. So that's what we clarified in the response that we sent back, that once those adjustments are made and you have a true accounting, if you will, which is what our financial statements look like in the way that we allocate. Once you've accounted for that, to take out the impact that we don't do in those cost reports, or at least not in the data source that was used for that metric, that's the issue. So there's two different data sources. One for the budget tool, it's cost report data that hasn't yet been adjusted for the allocation that we make for shared services versus what we're actually doing on our financial statements and the budgets that you're reviewing today.
Okay, so just to make sure I understand it, the calculation we have in our budget tool is all UVM Health Network shared services. The adjustment that you made in your letter takes it so it's just the apportionment of the network shared services that should be attributed to UVM Medical Center based on NPR.
Correct, except for the first part of your statement. It's not all network shared services, but because the UVM Health Network cost report has the vast majority of health network shared services in it, what our calculation is doing is taking that component and bringing it down to the 65%, if you will, net patient revenue component that the UVM Medical Center is actually paying for shared services.
And the cost report, you said it's not all of the health networks. Sure. So what parts are not in those cost reports?
So there is a piece of shared services that, again, when we aggregate them all together, there's a piece at CVMC, there's a piece at Porter, but they have, to give you an example, so an HR department, the vast majority of the HR personnel and costs are at the UVM Medical Center, meaning they are the employer of record. But there is, 2 or 3 people at CVMC. There is, a few people at Porter where they're the employer of record, which factors into the cost report. But the vast majority of the network shared services ends up on the UVM Medical Center's cost report because they have the bulk of those employees.
Okay. And is that kind of home office, if you will, issue, is that in any of your peer group cost reports as well? Is that problem unique to UVM, or do others have that issue?
So you definitely see, so everybody has a little bit different setup. Some networks actually have a separate corporate entity for their network shared services. So I think when you look at that tool and you look at some of those that are on the lower end of this, a separate network entity where they have no shared service costs running through their individual hospital cost reports. If you look at Dartmouth, for example, that's even further beyond the UVM Medical Center, which is the, if you scroll, if you highlight. So if you look at Dartmouth, for example, at 38%, I guarantee you the same phenomenon is happening there. The bulk of their shared services is running through, they don't have a separate corporate entity for network shared services. So the bulk of their shared service costs are running through the Dartmouth Hospital cost report. I have to assume they're doing the same thing where the actual costs, however, are being allocated based on some net patient revenue or other metric to their partner hospitals.
Okay. And these that are lower, Emory or Beth Israel or some of these lower ones, do they have that issue?
So again, I would suspect that they have a separate corporate entity for network shared services. So they have an Emory, a separate tax ID number, separate corporate structure for their shared services, that their shared service costs are not running through their hospital cost report.
Okay.
Does that make sense, Owen? Because I was confused by this as well initially.
I think it makes sense to me.
Okay, I just want to make sure.
So the other question is the contracted labor salaries. So you're basically saying that, our proportion looks misleading because we actually pay more for physician services, but it's just not in our cost report because we contract it out. How much money is that for UVM?
Which number are you looking for, Chair Foster? The FY24 budget or the?
Sorry, relating to this budget tool. So what is that, 21 or 22 data? You know what, why don't we first speed here? Why don't we have that as a follow-up? And, we're trying to make sure it's apples to apples. And so do you know whether or not the comparison group hospitals have misrepresented clinical labor costs because of this contracted labor services issue?
There could be some of that happening. What the other component potentially creating a mismatch in the comparison is just how much contract labor systems are using. There's wide variability across the country. So, for example, in more populated areas, or areas that haven't had to use as many contract labor resources in Texas, Louisiana, Mississippi, the South, their utilization of contract labor is much lower than in rural areas like ours. So there could be some some issues in terms of the cost report, but more likely what's creating that variation there is just the utilization of contract labor across the country.
Right. I want to shift topics to affordability, which is part of our mission and our review of this. When you set your commercial rate, is there any process in which you consider how much Vermonters can afford to pay?